concluding remarks.
I was just going to say, well, there's no need for introductions, Michael.
Yeah. Thank you, John. And what a wonderful company to be with, Adrian. Fantastic presentation and discussion. So I can't possibly bother you with details at the end of a second wonderful but long day. But I definitely want to say that this is to celebrate. And this is a slide which is familiar, known to you and published. I presented at the Minneapolis meeting on Friday in a keynote lecture on heart failure and transplantation to say this is truly a successful story in medicine. And I would suggest that when it comes to pulmonary hypertension in the context of congenital heart disease, this is also a cause for celebration. What we see here is Santorini. In 2003, this very meeting, we took it to Santorini, to a memorable few days, and you can see to the right the Nomikos neoclassic building where the meeting was held. It couldn't accommodate the numbers that we have today. And you can see here at the end of the ACHD symposium, we had an aspirational satellite on pulmonary hypertension. You can see AIDS has an impact on all of us. You can see some figures that are familiar. So it was at the time that there was no data to guide us. This paper and this graph, you saw it a number of times. It is important because it shows that when we look for evidence to guide our therapy, certainly the extreme end of the spectrum of ACHD pulmonary hypertension, we have evidence that has transformed practice, but these are the areas where the opportunity lies. For example, the systemic right ventricle, not in the double discordance, in the simple discordance. We had a wonderful presentation, and the winner of the abstracts from yesterday matched with a large cohort that Craig with colleagues have put together for what Thomas was telling us about looking for evidence in a prospective fashion. So coming back to where we are, we've come a long way from venesecting patients. So this is Middle Ages, but this is what was happening 20 years ago, and worrying about air filters and having patients on oxygen on wheelchairs into having some evidence to support other type of intervention. You can see here this pivotal study, BREATHE-5, which challenged the dogma of fixed pulmonary vascular disease, which is obviously not true. And you can see here how patients on active Busentan therapy improve their 6-minute walk distance by 53 meters, which is transformational. You can see the open label extension here that with further therapy, both the ex-placebo and the ex-Busentan continue to improve their objective exercise capacity and improve their functional class 2. This is a highly cited paper that Kostas Dimopoulos led from our group, published 10 years ago. And it was the first paper out of the large pulmonary hypertension community to show survival benefits of patients on advanced therapy at the bottom of this line compared to not a historic, but a contemporary cohort of patients on conventional therapy. That means not harming the patient. And you can see that clear diversion is present after propensity score analysis over a period of 4 years. From the same data set, you can see what ischemic complex is a progressive condition for the whole cohort of 229 patients, and even for patients with class 2 at baseline, with mortality all by half of patients at class 3. And it was soon after this date, or around the same time, that we start considering and proposing a goal-orientated, proactive approach, following very much the paradigm of the idiopathic pulmonary hypertension. So we wanted the patients to be on the green column. We want them to exercise well. We want them to have good echocardiographic markers. You saw this data from here of Wei-Lis and the team, and obviously addressing iron deficiency anemia too. We had the macitentan study, which was a big investment, and it was a neutral in its primary endpoint, but it told us that macitentan is a safe drug on the subset of patients who had hemodynamic assessment, and also on the NT-proBNP, as Kostas showed on his presentation yesterday. We had a positive effect of therapy, and we used macitentan for patients together with all the other therapeutic opportunities for them. This is almost a historic study from Columbia, from Erica and the late Robin Bass, to show that prostacyclin has a positive effect on these patients in terms of reducing pulmonary vascular resistance index and also improving the 6-minute walk distance. And there is a more recent report from treprostinil subcutaneous coming from a number of colleagues led by our senior presenter at the meeting, Irene Lang, to show a similar positive effect on an intention to treat cohort. This is similar experience from Maurice Beghetti and colleagues looking at selexipag in patients with background of congenital heart disease, but repaired lesions, a subset of the Griffon study operation. Alex showed this slide, so 6-minute walk distance, either baseline or difference or change in it is prognostic in this population, and this is the first attempt of having combination of stratifiers in prognostication for this entity. But then leaving just the 229 patients from the cohort here, the Brompton, and looking at a larger cohort, and that is an absolute necessity for us to progress, to work together. You can see a global operation with colleagues from around the world contributing to this, and you have 1,100 patients that give you robust data. So over a 3-year period in this relatively contemporary cohort, you got a lot of mortality and very few transplantations. On the univariate analysis, again, advanced therapy for PAH was a good thing for the patients. These are the basic clinical parameters, predictors of outcome. Age, pre-tricuspid shunt, discussed extensively during the course of the meeting. Oxygen saturation, the 6-minute walk distance, and the presence of pericardial effusion. And it was discussed and commented that the patients with atrial septal defect and isomonkey complex have a worse prognosis. The timing and mode of adaptation is clearly different in them. This is an unpublished table, and I was looking to find Alex today, who was busy in the catheter lab, to see. We haven't published this in the circulation data set, but it's an important slide because it tells us about 5-year mortality risk of patients based on these simple parameters. And you can see some patients with an atrial septal defect who are in these red or dark red boxes, the risk of mortality is 60%. And if they're on optimal medical therapy, clearly they should be on a transplant list. And again, coming back to this review from the European Heart Journal, you can see this mode of being proactive and going to combination therapy and being not reactive, proactive with our patients, as it is the case in other etiologies. But it's not just about drugs. It is also about the model of multi-organ disease, and that every single organ is affected. And I think we can say again that we have made some progress along this line. And if I take just the secondary erythrocytosis issue and the fact that there is no evidence for venesection, this is an abandoned procedure now, and that our stoic patients tolerate oral iron supplementation. And with that, in some ways, like what we saw from Heintenberg, from Eckhart, you can see that you got improvement of the quality of life specific PAH questionnaire comfort score after 3 months. And similarly, just by supplementing them with iron, improving the 6-minute walk distance by 30 meters, albeit this is not controlled data. And the session this morning and the talk by Eckhart was outstanding, and it's an area that's neglected. We need to invest further on it, because you can see again on this intention to treat cohort of ICD patients, just by physical training, you have a significant improvement on their 6-minute walk distance, and all this quality of life and important parameters. So transplantation, and we are lucky within the trust, and now the bigger sort of operation, bigger house, to have Hereford Hospital, which is assist device, advanced heart failure and transplantation center, and we must make better use of it. You can see the projection of transplant cases, heart and lung. This is from Costa's publication, the heart from last year. And you can see the projected need, which is much greater. So there's a mismatch at national level of the need for transplantation versus the provision for it. And if you look at the Brompton and Hereford data over a period of 12 years, you can see how kind of behind we are. And Pablo Meras published this data set in our journal, the big journal, just a few weeks ago. I think the question needs to come out from here. It's too little, too late, because out of the 10,000 patients or so that we look after, there were only 130 patients who had HLAs checked during this period of time, and only 17 ended up being transplanted. And those who did receive a transplantation did better than those who were on this brown pie. So just to conclude my presentation, how can we do better, not only for PAH, but for congenital heart disease, when we have increasing number of patients? And mind you, the ICD cohort may be coming down in places like the United Kingdom, but there are other mechanisms of pulmonary hypertension in our patients, maybe the very complex ones, maybe the single ventricle patients, the hypoplastic left heart. So I think we're going to stay busy here. Clearly, complexity of work, not for everybody, but for some patients, it goes up. And clearly, this is not work that can be done in small cottage places. It's tertiary work. I have been saying this for some time. We have not done a good job to empower the patient and the families. Yes, I think we're improving in becoming their advocate. I think this engagement and support of general cardiology in all aspects of the profession is essential, because we can't do this just at the Brompton when patients are all over the place and they have emergencies and so on. And my bias to this, I've come to the conclusion that the best way to affect this is to actually educate the patient. And the patient is the medium for the rest of the profession. This is a model that we are pursuing actively, and I think it's a unique opportunity for the patients, all patients with congenital heart disease, to have this very busy day where they're integrated physiology, all aspects of congenital heart disease are addressed, assessed, they're risk stratified, be that by conventional, and why not with artificial intelligence is here, and be provided with all this information which is necessary to answer life planning, education about their condition, what to do with an emergency, what to do with contraception, when to have children, what to do with exercise. These are our providers, multiple sources, and then from then on, actually favor the term personalized follow-up. And I know there are alternatives to it, but it's not about precision medicine. I am a pilot precision medicine, which is still the way that we talk to patients. It's about the patients themselves. It's personalized attention, education, empowerment, setting them free. And then we have more time at clinics. Now, the old model of bringing patients every year to assessing with this and that test, I think is archaic. So low-risk patients can go back to the community and we can still monitor them remotely. Medium risk and high risk clearly need to stay in closer contact with us. and we're about to pilot and see whether remote monitoring is, in the first instance, feasible, whether patients are interested, and whether it's safe before we go into looking at closer. We are investing here in London. I think London is an amazing city, 1,000 years of unbroken history and rivalry with it. But, you know, with that, there are a lot of good things that are happening. What you see here is the imaging center, which is a building site within the Brompton current site. And of necessity, coming together with St. Thomas's and guys, very excited about it. We have Hereford, which is some distance, and yet has been tremendous help to have during the COVID epidemic and pandemic. And we have obviously their transport expertise, which are necessary. So, and then technology. And there you are. I joked earlier on about catching our flight. You don't need to catch a flight. And we can communicate as we did during the pandemic using webinars, using fellows clubs, using digital communication. By the way, Adrian, your webinars from the West Coast were an inspiration, and we had similar things at this end. And that was very reassuring for the patients. So the opportunity with technology is endless. And I would start at the bottom here. It wasn't discussed a great deal. I would like to use technology for education. I would like to education empower the patients. I think there's opportunity for monitoring with technology. And Gerhard said it all. I don't have much to add on artificial intelligence. And I'm very keen to see when I was going to ask this question, there was no time, and I spoke a lot of these 2 days. When are we going to have artificial intelligence giving us volumes on the spot? So then if a patient comes and has an echo or an MRI as they need at that hub, at the imaging center, I have all these results on the spot. And then I sit with the patient, I sit with Hajar, with the clinical nurse spaces, with Claire, and we give them all this. And we started building up an educational empowerment tool on our website at the Brompton. Slowly, do visit it. Why should the patients not know what is exposing them more to endocarditis, for example? It's not the antibiotics, whether they make any difference or not. Nobody knows. But if you're slim and athletic, if you don't have paronychia, if you don't bite your nails, if you don't smoke, if you go to cooking, then the risk of infection is lower. Whether you're a congenital patient or you are any of us, in or out of the pandemic. So that's the future, the way I see it. So I call it not precision medicine, I call it personalization care. I would like to see a smooth transition, and I said that before, I repeated myself. Transition starts at the time of fetal diagnosis. If the family understands that this is a lifelong disease, but for the majority of patients, the outlook is excellent, what's the problem? And there is infrastructure to support them. It is a multidisciplinary operation. It's a lifelong partnership that I would like to see with the patients. Lifestyle issues now are addressed better, including reproduction. Timely interventions, plenty and challenging, multiple interventions, press on the system. We need more evidence, colleagues, and we need to work together. We need to grow up. I think that's the opportunity now. Transplantation, we can make better use of it and devices. And that leads to life enrichment of all patients. So our Baroness Sally Morgan at the opening brief talk of the meeting alluded to this. This is just a first step with the support of the trust here to working with humor to have a very basic ACHD application targeting a small number of patients in the first instance and seeing how feasible that is, how interested they are, and what you can learn from it. Thank you.
Thank you, Michael. That was an amazing overview and thoughts for the future. I'm just going to see if there are any questions coming through. I mean, in the meantime, I had a few questions. Physical training, you mentioned that a lot, sort of being slim and fit.
How do you do it?
How do you do it? That's my question. How do you, what are your views on how we do it? Because unfortunately we can't provide the kind of Heidelberg model that we would all like to provide. So how do you think we can do that?
By way of example, John, in the first instance, and bridging the subject and reassuring the patients, I think everything that Adrian said, word by word, is applicable to our patients. Okay, so we can't tell the patients to sort of be slim and athletic if we are, sorry, Stefan Anker, nothing personal. So I think there will be more influence if we do this by way of example. I think we need some more data. So this is a blunt statement that I'm making. And there is data to suggest clearly that there is prognostic information on exercise, improved exercise capacity that we can extract or defer that is improved outcome. But it's not just living longer. It's the quality of life. It's the potential impact that it has on other systems, autonomic nervous function, discuss it, on immunity. And that is not to be seen in isolation. It needs to be seen in conjunction with other sort of lifestyle choices, like diet. And Daniel was right that we need to tell them early, but actually we need to give them, by way of example, in our households, that food is important and we make time for it. So I think there is opportunity, and you can have structured programs to take the rehab and so on, but I think we can positively reinforce all these things to our patients. And the patients are very bright. And what I do now, and maybe this sounds again a fantasy, and I would like Adrian to comment on this, I talk to patients, as I said earlier on, about cooking, about exercise, and I ask them to send me little cards with their weight every 6 months. Some of them won't, but, kind of an incentive. Maybe this is not appropriate. But yes, it would be nice if we had obviously big labs, but again, we wouldn't be able to channel every single patient through this, John. So I think reinforcement is important, and reassurance too.
I mean, it seems to me that we have to change the structure of the, how we follow patients up. I mean, you put that in your slide that perhaps we see patients too frequently face-to-face at the moment, and that we need to spend less time but more in-depth time to cover the psychological aspects, the dietary, everything like that. We have to change the way we practice.
We need to rebalance the relationship with the patients, John. We still talk down to the patients, and that's such a fundamental mistake. I'm convinced. Adrian, you say what you think. Obviously, I have a passion about it, and I'm overwhelmed by it. But yes, I think we need to reduce the traditional clinic visits, because they're not particularly helpful.
Well, so I think anything that keeps patients engaged is a good thing. And so whether that's coming in person, and I think, the other thing is we don't all live in countries where we have, you can easily drive to an ACHD center. And so I think we have different versions in Canada and the US versus Europe about what is a long time to drive. So in Toronto, we'd have people driving 10 hours to come to their clinic appointment. So I think that anything we can to keep people engaged is important. But getting to the question about healthy lifestyle, diet, and exercise, there's a trans-theoretical model or stages of change model, and you help people move from pre-contemplation to contemplation to preparation to action and maintenance. And one of the things you learn is that one of the first steps is to figure out why it's important to that person individually, so that they look at the pros and cons of behavior change. What are the advantages of being at a lower weight, or of exercising or eating healthier? What are the challenges, so that they themselves make an informed decision? When I talk to patients, and we go over this, because I would say, if I was in London, I would say, Dr. Gatzoulis is really encouraging this, but I guarantee he's not going to show up at your house every morning with prepared meals and grab your hand and say, let's go for a walk. So We want people doing things because they think it's the right thing for them. And so asking them why it's important that they have a healthy lifestyle. And everybody has a different answer. So, nobody has the same two parents or children or friends or hobbies. So to figure out, to say, why is it important that you stay mobile and fit, and that we help you live as healthy and long a life as possible. And so I think tying it back to something that is meaningful to them, and keeping a note of that in the chart to say, I know last time you said that your goal was to be able to go for a long walk with your kids or your grandkids. Have you been able to do that? So I think personalizing these goals, and you mentioned personalized medicine, I think it's that personalized goal setting can be very, very powerful.
Thank you, Adrienne. It must be
nice.
So thanks. And obviously I need to be wrote down, but and this is not going to happen tomorrow. I'm not suggesting the complete distraction of the model, but at the same time, what we have seen now out of these unforeseen, unprecedented circumstances, we have seen a lot of advantages with it and disadvantages, and we're still here. The same for the patients. I think the patients are ready. I believe the patients are ready. Not everybody, but I'll come back reporting on this very sort of early scratch of experience.
Yeah.
I will do a report back. Ultimately, what we want here, we want the patients to have the richest possible life. That's what we want.
Yeah. And that's what they want. They might define it differently, but they I think that is what they are hoping for also. That's why they come to clinic. That's why they engage with you, is that they are looking for their best possible outcomes as well.
So I think there's opportunity here and a long way to go. Don't take me wrong. This is not going to happen tomorrow. So those who are imaging consultants, your work, of course, is invaluable. We're not going to take the MRI or the echo away from your daily practice. And artificial intelligence, as Gerhard told us, is not going to put us all on a shelf. There's no substitute to personal contact and touching and talking to patients.
Yeah.
But I think we can do a better job educating the patients. And there's no excuse for not doing that, because, there's technology. Why do we get a patient who has paronychia for 4 weeks admitted with staph endocarditis? I mean, this is Zimbabwe with resources, with all due respect. And I don't blame the patients, I blame myself. So I want to make this better. Is that too complex? Just to give some other aspects of this remote monitoring. We have Newcastle, they're doing a fantastic job for transplantation, amazing job. And they were part of this Minneapolis, obviously, meeting on Friday. But how can they cope with patients from all over the country? Or bigger problem for you with larger land in Canada and the United States. Why should it be that a PAH patient on a transplant list on drugs needs to be, let's say, at Sheffield or in Newcastle to be transplanted, John? Why can we not sort of do some monitoring on this patient so this patient stays sane in their own environment?
No, I agree.
So lots of opportunity here, but it won't happen tomorrow. You just need to fight for it.
Michael, if you were to take one thing forward for the next 5 years, you think it's going to make the biggest difference to the patients, what would it be?
I think we need to work together and work with the patients and put the patients kind of almost in the leading position. I know that Jane is with us. It was wonderful to talk to her. She would think that I'm totally crazy, but times have changed and the patients need to be part of it, at the heart of it. And that's what Adrienne says, to understand why this is important, understand that in good time, and then they have a choice, as we do when we consider sort of an intervention that may be high risk. It's not our decision, it's the patient's decision. So we need to work together. We're not a Cinderella specialty any longer. We need to come together because we need the numbers. And I think this is happening now. In North America and Europe, there's a lot of opportunity now. And we need to capture this. But we need to have the patients. And the patients are also much more influential than us in securing resources. We need resources for this. And all this technology and advance, if we get an application to guide the patients from the time of diagnosis, you know where that is going to be much more valuable? Not in Canada and the United Kingdom that we have plenty. It'd be much more valuable in Africa. That is a global disease. And everybody now has a mobile phone. So that's a vision. And then you got the societies, and Adrian is staying on the platform. I think Gerhard, we have Pastora. So join, when we say work together, join the International Society of Adult Congenital Heart Disease, join the working group of the European Society of Cardiology, so we have a larger voice. We're not just 800, we're 8,000. Why not 80,000? Why not engage with other professionals that are part of this operation? Because, this is 1% global. So join your local societies, create patient associations if you don't have them. They're very powerful. And they can support much of this. Yes, it is happening here to some extent, the PAH Association, the Somerville Foundation, the American Heart Association. I think Amy Verstappen, I hope she is in this call. And we had Carl Worm with us from Munster. I'm so sorry, Carl, that there was no time to interview you earlier on, but you've done a fantastic job to support Munster, major benefactor, and the joint fellowship between Munster and us. So we need all this help, and we need industry to help us too. The advance that you saw with ICMANG patients would not have happened without industry support. And not just the drugs, the understanding of mechanism, throwing venesections out of the window. We're measuring to take 200 or 300 mils of blood and air filters. No evidence. Harmful for the patients. So I think we need just to stay on this line, John, and I'm very optimistic there will be a lot of good things to come. But it seems to me, out of the virus, paradoxically, we can accelerate certain things. And I'm all for it. I'm very excited. And I think the patients are ready, Adrienne, from what we see. And we need to follow them. Sorry, this is... it can't be longer. I apologize. I'm overwhelmed. But,
I don't think you need to apologize, Michael. Your enthusiasm is infectious, no pun intended.
Similar with you, John, and that's how we've done things. That's why, we continue to learn, and it's terrific. I don't think there are more questions. Shall we wrap up?
There are just some comments, Mike, just about how wonderful the meeting's been, and thank you for your hard work. And I think it's an obvious opportunity for us to say thank you from everyone, the delegates, the speakers, and the chairs for you driving this forward, all the previous meetings and transforming them to this wonderful new form, which is still excellent. And obviously we like to see people face to face and give them a big hug, as you say, but hopefully in the future there'll be a hybrid, because I think this will provide
absolutely, John. And I won't possibly do this without the support from